So here are the workshop objectives. They've been trimmed down a bit. There usually used to be about 10 of them. And I think they're very formal language register. But I think basically as you put this up, you could say that this is the Bridges lens for understanding economic class and how that has an impact on health in terms of patient engagement, in terms of models of institutional services, and as well as community initiatives. So typically, what kind of audience do you expect to be presenting Bridges to Health and Healthcare? Would you be presenting to a hospital staff? Would you be presenting to a community? Would you be presenting to healthcare providers, public health? Does anybody have any idea at this time? Okay, Sean has responded in questions. Susie says health team and public health. And Sean is saying hospital staff for use at the hospital. So there's a slightly different approach for community health, perhaps, than there would be for those that are providers. Providers may be very interested in that one-on-one patient engagement. And community stakeholders may be interested in improving health throughout the community. So we are looking again at the third bullet now, provide strategies and solutions at the individual, institutional, community, legislative, and collective efficacy lenses. And I think that the main thing is that with Bridges to Health is you have to create a business case. You have to make the business case. So Module 1 helps you make the business case even before you would offer Bridges to Health and Healthcare. You should probably talk to some people who have, as I say, influence as well as vision, and talk about how Bridges to Health and Healthcare is not just about doing the right thing. It's not just about creating access, but it's about how we engage one another and how we improve health. And so we will give you the best slide I know of, which is the triple aim to make the business case to how it's actually going to save the health system money and save the community money and funding if you actually have better health outcomes. I think the biggest piece is this, that 80% of the health resources are being used by 20% of the individuals. And I think that creates this kind of tension within healthcare as well as community health, because you have a smaller number of people who are using the health system. And sometimes in clinical health, folks are called frequent flyers. It's interesting that in one of our champions called those folks they keep seeing all the time familiar faces. And different systems have different ways of identifying who's at risk. So they'll do needs assessments of their patients, in other words. And a lot of those are defined by the condition or the disease. So if someone is a brittle diabetic or if someone has COPD, they're sort of flagged as somebody who's a high-end user of health services. What we're saying also is that poverty can create the environment where I would be more likely to use the emergency department than have a primary care physician. Some of that is because of insurance, but some of that is because of the tyranny of the moment. And all of you are Bridges trainers, certified trainers, so you know what I'm talking about. You know, I'm not really going to go over the Bridges lens. I'm going to go over the application of the Bridges lens. So hopefully, you know, you are very familiar with that Bridges lens, and we can start adapting that. So that tyranny of the moment is sort of that description of mental model of economic class of poverty is so powerful also in helping the system to see that you can't just use disease and condition to imply the forecast the at-riskness of a patient who may be a high-end user or may become a high-end user. And so I have seen some of the tools that are used by systems, healthcare systems, and they'll have, people who are very low risk users, they identify by certain criteria, then middle users, who may eventually become high-end users, and then they'll have twos for high-end users. But what we're very closely aligned with here is population health. And so what we're saying is you have to look at your patients not just by disease, but by population. And let's not forget to look at economic class and not just race, gender, ethnicity, orientation when it comes to defining populations that have been marginalized.